Welcome, curious minds, to the deep dive. Today, we're embarking on a really fascinating journey into the sophisticated world of skeletal muscle relaxants.
It really is sophisticated.
Imagine, just for a moment, the intricate dance of our muscles, allowing us to move, speak, even breathe. Now, picture scenarios where that control is either purposefully suspended, like in life-saving surgery, or maybe tragically impaired, like with debilitating chronic pain, or those involuntary muscle contractions.
Right, and these are the realms where muscle relaxants operate.
Exactly.
Indeed. Our mission in this exploration today is not just to scratch the surface, but to really dissect this intricate landscape.
Get right into the weeds.
We're going to explore how these, remarkable compounds manipulate the very fibers that allow us to move. Everything from the cellular nuances right up to the physiological impact.
Okay.
Our goal really is to gain what you might call an elite professional's grasp of this subject. We'll be exploring everything from, surprising origins in ancient arrow poisons,
That part's vague.
all the way to the cutting-edge pharmaceuticals that are reshaping modern medicine today.
And to guide us on this exploration, we've gathered, quite an extensive stack of sources, a real trove of articles, research papers, clinical insights.
Good stuff.
Yeah, and these aren't just dry facts. They're more like a roadmap, helping us uncover surprising truths, some captivating historical notes, and the essential nuggets of knowledge you need to be truly well-informed on this really critical area of pharmacology.
Absolutely. Let's dive in.
So let's begin. The dual nature of muscle relaxants. Paralysis versus spasm relief. All right, so when we casually use the term muscle relaxant, I think it's easy to think of it as just one single category.
Yeah, people tend to lump them together.
But our sources reveal it's much more nuanced than that. It's like saying tools. I mean, are you talking about a simple hammer or some complex robotic arm?
That's a great analogy.
Skeletal muscle relaxants are actually split into two very distinct therapeutic groups, each designed for entirely different purposes.
Exactly. Think of them as maybe two specialized branches of medicine, each focused on a unique aspect of manipulating muscle function.
Okay.
That's a perfect way to frame it. At their core, these drugs address fundamentally different clinical needs. So on one side, we have the neuromuscular blockers.
Right.
These are primarily used to produce complete but temporary muscle paralysis.
Complete paralysis.
Yes, and this state is absolutely essential in modern surgical procedures and also for managing patients in intensive care units. A key insight here, and this is really important, is that these drugs work specifically at the neuromuscular end plate.
The junction.
Exactly, that precise junction where a nerve connects to a muscle. And crucially, they lack central nervous system activity.
So they don't affect the brain.
Correct. This means they don't directly affect your brain function or consciousness. You wouldn't be awake and paralyzed from one of these. They're always given in conjunction with general anesthesia.
Okay, so these are the drugs that allow a surgeon to operate on, say, an abdomen without the muscles tensing up, or maybe help safely insert a breathing tube.
Precisely. They are indispensable adjuncts during general anesthesia. By providing that profound muscle relaxation, they optimize conditions for surgeons, particularly, like you said, during procedures involving the abdominal or thoracic cavities.
Makes sense.
And they also critically facilitate endotracheal intubation, which is, inserting a breathing tube into the trachea. This ensures adequate ventilation and protects the airway throughout the anesthesia.
Crucial stuff.
Absolutely. Without them, complex surgeries needing that still relaxed surgical field would either be far more invasive or maybe just impossible without inducing dangerously deep levels of anesthesia, which of course carry their own significant risks.
Right.
Now, on the other side of this pharmacological coin, we have spasmolytics and antispasmodics.
Okay, the second group.
Yes. These drugs are traditionally referred to as centrally acting muscle relaxants. And that term, centrally acting, is key here because it immediately signals that, unlike the neuromuscular blockers, these do have activity within the central nervous system.
Okay, big difference.
Huge difference. Their primary use is entirely different, too. They are employed to treat painful conditions characterized by muscle spasms or chronic spasticity.
So things like back pain.
Exactly. Think of conditions like persistent back pain, muscle strains, or maybe the debilitating stiffness associated with neurological disorders like multiple sclerosis. Their aim is really to reduce those involuntary muscle contractions and the associated discomfort, helping individuals regain some function and find relief in their daily lives.
And then there's dantrolene, You mentioned that briefly as being kind of unique, not fitting neatly into either group. Where does it fit?
Yeah, dantrolene really occupies a special niche. Unlike those centrally acting spasmolytics, it has no significant effects on the central nervous system.
Hmm.
And it's not a neuromuscular blocker in the way we typically think of drugs used for surgery. Instead, dantrolene is primarily used to treat a rare but critically life-threatening anesthetic-related complication, malignant hyperthermia.
Ah, right, MAGE.
Exactly.
Yeah.
It's a unique mechanism of action, which we'll definitely get into later in more detail, involves directly affecting the muscle's contraction process itself. It sort of bypasses the nerve to muscle transmission or central reflexes entirely.
So it works right on the muscle fiber.
Precisely. It's a powerful example of a highly targeted intervention. 2. Neuromuscular blocking drugs. Unraveling the mechanism of paralysis.
Okay, let's zero in on those drugs that induce paralysis, the neuromuscular blockers. What's absolutely fascinating, and you touched on this, is their origin, tracing back to the 16th century.
It really is remarkable.
I mean, it's truly amazing to think that a poison used by indigenous peoples in the Amazon basin for hunting would become one of the most transformative tools in modern surgery. We're talking about curare, right? That legendary arrow poison.
It's a profound testament to scientific discovery, isn't it? The active compound isolated from curare was d-tubocurarine.
D-tubocurarine, okay.
Right. This substance and the numerous synthetic analogs that chemists later developed based on it, well, they revolutionized the practice of anesthesia and surgery.
How so?
Well, before neuromuscular blockers, achieving the muscle relaxation needed for complex operations required dangerously deep levels of general anesthesia.
Which we mentioned carries risks.
Exactly. Severe risks, particularly to the patient's cardiovascular and respiratory systems. The introduction of these compounds allowed for much lighter anesthesia while still providing the necessary muscle relaxation, which dramatically improved patient safety.
Makes sense.
But beyond just its clinical utility, curare also proved invaluable in helping us understand the fundamental mechanisms of neuromuscular transmission itself. You know, how our nerves actually communicate with our muscles at that microscopic level. It really unveiled a whole new physiological frontier.
That's where it gets truly captivating. So let's break down this neuromuscular transmission, this incredibly precise synaptic dance at the motor end plate. How does a nerve signal actually tell a muscle to contract, like molecule by molecule?
It's a masterpiece of biological engineering, really. Picture the motor end plate as this microscopic, highly specialized communication hub where the motor nerve terminal meets the muscle fiber.
Okay.
The process kicks off when an electrical signal, an action potential, arise at the nerve terminal. This triggers a rapid influx of calcium ions into the nerve ending.
Calcium rush.
Exactly. This calcium influx is the crucial signal that prompts the release of a chemical messenger, a neurotransmitter called acetylcholine, or AKI. Right. It's released from tiny sacs called vesicles within the nerve terminal.
Like little packets of information being released into the gap.
Precisely. Once released, acetylcholine diffuses across a minuscule gap, the synaptic cleft, and then binds to specific receptors located on the muscle fiber's motor end plate.
The nicotinic receptors.
Yes, nicotinic acetylcholine receptors, and they are incredibly dense on that muscle membrane. Now, to activate these receptors and open their ion channels, 2 acetylcholine molecules must bind to specific sites on the receptor.
2 molecules, like a double lock.
Kinda. Think of it like a very complex lock that requires 2 specific keys turning simultaneously for the gate to swing open.
Okay.
This dual binding causes a shape change in the receptor, opening an ion channel embedded in the muscle membrane. This opening allows the rapid movement of sodium ions into the muscle cell and potassium ions out of the cell.
Ions flowing.
Right. This specific ion movement leads to a rapid, graded depolarization of the end plate membrane, which we call the motor end plate potential.
Okay.
Now, if this electrical potential is strong enough, if it reaches a certain threshold, it then triggers a full-blown action potential that propagates rapidly along the entire muscle fiber.
The signal spreads.
Exactly. And this electrical signal is what ultimately initiates the complex cascade of events leading to muscle contraction through a process known as excitation-contraction coupling. Wow. And to ensure the muscle is ready for the next signal almost immediately, the released acetylcholine is very quickly removed from the end plate region. This happens mainly through diffusion and, critically, by rapid enzymatic destruction by a local enzyme called acetylcholinesterase.
Break it down fast.
Very fast. This rapid removal ensures precise, short-lived muscle contractions.
That's incredibly precise and efficient. But you also mentioned that there are other types of acetylcholine receptors beyond this main junction. Are these important in, a clinical context?
They are indeed important, yeah. And understanding them definitely brings us closer to that elite professional's grasp of the subject we're aiming for.
Okay.
Besides the primary nicotinic receptors on the motor end plate, there are at least two other types of acetoreceptors within the neuromuscular apparatus. One type is found on the presynaptic motor axon terminal itself.
On the nerve end.
Correct. When activated, these receptors play a role in mobilizing additional neurotransmitters, essentially preparing more acetylcholine vesicles for subsequent release. It kind of fine-tunes the efficiency of nerve-to-muscle communication.
Got it. And the second type?
The second type are extrajunctional receptors. Now, these are normally sort of dormant and not involved in everyday neuromuscular transmission. However, under specific, often pathological conditions like prolonged immobilization, severe thermal burns, or certain nerve injuries, these receptors can proliferate significantly.
Proliferate, meaning they multiply.
Exactly. Their numbers can increase dramatically. And what this means for you, the listener, is that when this happens, it profoundly affects how muscles respond to both depolarizing and non-depolarizing skeletal muscle relaxants.
Okay. So this has real clinical impact.
Huge impact. This proliferation is a critical insight, as it directly links a seemingly obscure molecular detail to significant clinical implications, particularly the risk of hyperkalemia, which is high potassium, when succinylcholine is used in these patients. That can be life-threatening. This is a true aha moment that ties molecular biology directly to patient safety.
So with that precise understanding of normal function, how do these drugs actually disrupt it? You mentioned two basic mechanisms. How do they fundamentally cause paralysis?
Right. So there are two fundamental ways neuromuscular blocking drugs achieve their paralytic effect. First, we have non-depolarizing blockade.
Okay.
This is characteristic of most of the neuromuscular blocking drugs currently in use, with d-tubocurarine being the historical prototype. These drugs work by competitively preventing acetylcholine from binding to its nicotinic receptors on the motor end plate.
So they just get in the way.
Essentially, yes. By occupying the binding site without activating the receptor, they prevent the ion channel from opening and thus prevent the depolarization of a muscle membrane, leading to muscle relaxation. It's like putting a non-functional key into a lock. It just sits there, preventing the correct key, acetylcholine, from entering and turning.
Okay, that makes sense. What's the second mechanism?
The second mechanism is depolarizing blockade. This is produced by an excess of a depolarizing agonist, with succinylcholine being the sole clinically useful drug in this class.
Succinylcholine.
Right. It's a seemingly paradoxical effect where a drug that actually mimics acetylcholine, which normally activates muscle, somehow causes paralysis. We'll delve deeper into its unique two-phase action shortly, but essentially, succinylcholine activates the receptor in such a prolonged way that it ultimately renders the muscle unresponsive.
Huh. Weird.
It is. While other substances like, say, high concentrations of acetylcholine itself, like you might see in cholinesterase inhibitor intoxication, or even nicotine can also cause a depolarizing block, they aren't clinically useful because you just can't control them precisely enough.
Okay. It's incredible how these compounds are engineered. On a chemical level, what makes them work the way they do, and how does our body process them?
Chemically, it's quite an elegant design, actually. All the available neuromuscular blocking drugs share a structural resemblance to acetylcholine.
They look like acetyl.
In a way, yes. For example, succinylcholine is essentially two acetylcholine molecules linked end-to-end.
Okay.
For the non-depolarizing agents, like pancuronium or rocuronium, their structures cleverly conceal this double acetylcholine motif within bulky, semi-rigid ring systems. These typically fall into two major chemical families, the isoquinoline derivatives, like atracurium,
Right.
and the steroid derivatives, like pancuronium and rocuronium.
Steroid-based. Interesting.
Yes, but a critical property common to all currently used neuromuscular blockers is the presence of one or two quaternary nitrogens in their chemical structure.
Quaternary nitrogens. Why is that important?
It's crucial because this particular feature makes them highly polar and poorly lipid-soluble.
Meaning they don't dissolve well in fat.
Exactly. And why is that so crucial? Because it severely limits their ability to cross the blood-brain barrier and enter the central nervous system.
That's why they don't affect the brain.
That's the key insight. It explains why these potent paralyzing agents don't affect your brain directly or cause sedation. Their action is primarily confined to the periphery, to the muscles.
So because they're so polar, they can't be given orally, right? They have to be injected.
Exactly. All neuromuscular blocking drugs are highly polar compounds and are inactive if taken orally. They must be administered parenterally, typically intravenously, to exert their effects.
Okay, let's talk pharmacokinetics then. How does the body handle them once they're injected? Let's start with the non-depolarizing ones.
Right, so the non-depolarizing relaxant drugs. After intravenous administration, they typically show a rapid initial distribution phase. They quickly spread through the bloodstream to reach the neuromuscular junctions, followed by a slower elimination phase.
Okay.
Now, since they are highly ionized, they don't readily cross most cell membranes or bind extensively to peripheral tissues. This means their volume of distribution is relatively small, really only slightly larger than the circulating blood volume itself.
So they mostly stay in the blood.
Largely, yes. And crucially, the duration of the neuromuscular blockade produced by these drugs is strongly correlated with their elimination half-life.
Makes sense. Longer half-life, longer action.
Precisely. Drugs that are primarily excreted by the kidney, like the older drug tubocurarine or pancuronium, generally have longer half-lives, which translates to longer durations of action, often exceeding 35 minutes. Conversely, drugs predominantly eliminated by the liver tend to have shorter half-lives and durations of action.
Okay. What about those steroid ones you mentioned, like pancuronium, vecuronium, rocuronium?
Good question. Those steroid muscle relaxants are metabolized in the liver into various products, typically 3-hydroxy or 17-hydroxy derivatives. Now, while these metabolites are generally less potent than the parent drug under normal circumstances, they usually don't accumulate enough to cause significant prolonged blockade after just a single standard dose. But here's a critical clinical implication. If these compounds are administered for several days, say, during a prolonged infusion in an ICU setting, the metabolites, particularly the 3-hydroxy form, can accumulate due to their longer half-lives.
Accumulation leads to problems.
Exactly. This accumulation can lead to prolonged paralysis, which is a significant challenge in critical care management.
Okay.
The intermediate-acting steroid muscle relaxants, vecuronium and rocuronium, are more dependent on biliary excretion and hepatic metabolism for their elimination. This means their duration of action can be significantly prolonged in patients with impaired liver function. That's a crucial practical consideration for clinicians.
Definitely. What about atracurium? You mentioned it was an isoquinoline derivative.
Right. Atracurium is an intermediate-acting isoquinoline non-depolarizing muscle relaxant, and it has a truly unique way of being inactivated. In addition to some hepatic metabolism, it undergoes spontaneous chemical breakdown in the body, a process known as Hoffman elimination.
Hoffman elimination, spontaneous breakdown.
Yeah, it doesn't require enzymatic activity. It just happens chemically at body temperature and pH. Its main breakdown product, ladanacine, doesn't have neuromuscular blocking properties, but it is slowly metabolized by the liver and has a longer half-life.
Okay, so what's the clinical significance of ladanacine?
The significance is that ladanacine readily crosses the blood-brain barrier. While typically at low levels during surgery, with prolonged infusions of atracurium in the ICU, ladanacine blood levels can rise, and at high concentrations, it can cause seizures.
Seizures, okay, that's serious.
It is.
And isn't that where atracurium comes in? I think you mentioned it's one of the most common muscle relaxants used today. What makes it so preferred?
You're absolutely right. Succinylcholine is a potent stereoisomer of atracurium, and yes, it has largely replaced atracurium in clinical practice.
Why is that?
The reason why it's so important and widely used is that it offers basically all the advantages of atracurium, but with significantly fewer adverse effects. Crucially, succinylcholine is more dependent on that Hoffman elimination pathway and less on hepatic metabolism.
So less laudanacine production.
Much less laudanacine production. This significantly reduces the risk of CNS effects like seizures. Additionally, it causes much less histamine release compared to atracurium.
Less histamine means less risk of low blood pressure.
Exactly. Lower risk of hypotension and other allergic-type reactions. So, from a clinical perspective, it's just a cleaner, safer alternative.
Makes sense why it's so popular then. Are there any new ones on the horizon?
Looking to the future, yes, there's ganticurium. It's a novel, non-depolarizing neuromuscular blocker, currently still in phase 3 clinical trials.
Ganticurium, okay.
Yeah. Preclinical and clinical data suggest it has an extremely rapid onset and a very short, predictable duration of action, actually similar to succinylcholine, which is still the gold standard for rapid onset.
Wow, rapid onset and short duration. That sounds useful.
Very useful. What makes it unique is its non-enzymatic degradation. It's broken down by cysteine and ester bond hydrolysis, allowing for rapid and predictable elimination.
So it can be reversed quickly, too.
Yes, it can be rapidly reversed, not just by the standard reversal agent neostigmine, but even more quickly by simple L-cysteine.
Interesting. Any downsides?
Well, higher doses have shown some cardiovascular effects like hypotension, probably due to histamine release. But importantly, it hasn't been associated with bronchospasm. So yeah, it's a very promising agent for situations needing that ultra-rapid onset and offset.
Okay, so shifting to the other side of the coin, how about the pharmacokinetics of the depolarizing relaxant drugs, namely succinylcholine? It's famous for being incredibly fast-acting and short-lived.
Indeed. The defining pharmacokinetic feature of succinylcholine is its extremely short duration of action, typically only 5 to 10 minutes.
It's really short. Why?
This brevity is due to its incredibly rapid hydrolysis, or breakdown, by two enzymes, butyrylcholinesterase, found in the liver, and pseudocholinesterase, which is predominantly in the plasma.
So enzymes in the blood chew it up quickly.
Very quickly. Succinylcholine is broken down first into succinylmonocholine and then further into succinic acid and choline, which are inactive. Now, because plasma cholinesterase has such an enormous capacity to hydrolyze succinylcholine, only a small percentage of an intravenous dose ever actually reaches the neuromuscular junction to cause the block.
So most of it gets destroyed before it even gets there.
A large portion, yes. Furthermore, because there's very little plasma cholinesterase right at the motor end plate itself, the blockade produced by succinylcholine is primarily terminated not by enzymatic breakdown at the synapse, but actually by its diffusion away from the end plate into the surrounding extracellular fluid.
So it just drifts away.
Essentially. So the circulating levels of plasma cholinesterase are critical because they determine how much of the drug actually makes it to the motor end plate in the first place to exert its effect.
And I've heard about genetic variations that can impact how someone responds to succinylcholine. That sounds like a fascinating point that connects directly to patient safety.
It is, and it's a crucial one for achieving that elite professional understanding. Neuromuscular blockade produced by succinylcholine can be significantly prolonged, sometimes for hours, in patients who have an abnormal genetic variant of plasma cholinesterase.
Meaning their body doesn't break down the drug normally.
Exactly. Their enzyme just doesn't work as efficiently. To identify these at-risk patients, clinicians can use a test called the dibukane number.
Dibukane number, how does that work?
Think of it this way. The chemical dibukane inhibits the normal enzyme by about 80% under standardized lab conditions. But if you have the abnormal genetic variant, dibukane only inhibits it by about 20%.
Big difference in inhibition.
A stark difference, yes. That tells us who might experience a much longer-lasting paralysis from succinylcholine.
Okay. Is this test done routinely?
No. Given the rarity of these clinically significant genetic variations, plasma cholinesterase testing is not a routine clinical procedure. However, it is indicated for patients who have a known family history of plasma cholinesterase deficiency or prolonged paralysis after anesthesia.
So what's the takeaway for the listener?
For the listener, a very reasonable and practical strategy is simply to avoid the use of succinylcholine where possible in patients with a known or suspected family history of this deficiency. The risk of prolonged paralysis and potential respiratory compromise is just too great to ignore in those cases.
Okay, that makes sense. So we've talked about the drugs themselves, their chemistry, how the body handles them. Now, let's get into the nitty-gritty. How exactly do they manipulate that tiny receptor at the molecular level to cause paralysis? What's the precise mechanism of action?
Right. This is where our understanding truly becomes nuanced. We can describe the interactions of these drugs with the acetylcholine receptor and the end plate channel at a really molecular level.
Let's do it. Start with the non-depolarizing ones again.
Okay, the non-depolarizing relaxant drugs. As we discussed, almost all the neuromuscular blocking drugs currently in use, except for succinylcholine, fall into this category. At small doses, these drugs act predominantly by competitive antagonism.
The blocking the keyhole mechanism.
Exactly. They simply compete with acetylcholine for the binding sites on the nicotinic receptor. By occupying the receptor without activating it, they prevent acetylcholine from binding and initiating a muscle contraction.
Okay.
Now, here's a counterintuitive but fascinating detail. The least potent non-depolarizing relaxants like rocuronium actually have the fastest onset of action.
Least potent is fastest. How does that work?
It's because you need a higher molar concentration of a less potent drug to achieve the desired effect. This higher concentration means more drug molecules arrive at the receptor sites more quickly, facilitating a rapid block.
Ah, okay, more molecules flooding the area faster.
Precisely. Now, at larger doses, these non-depolarizing drugs can do something more than just compete. They can physically enter the pore of the ion channel itself.
Get inside the channel.
Yeah, this channel block produces a more intense motor blockade. So this dual action, both competitive antagonism at the binding site and physically blocking the channel pore, significantly weakens neuromuscular transmission.
And that makes it harder to reverse.
Exactly. It diminishes the ability of acetylcholinesterase inhibitors, the drugs we use as reversal agents, to effectively reverse the effect. If the channel is physically blocked, simply increasing acetylcholine levels at the synapse won't be nearly as effective. Furthermore, non-depolarizing relaxants can also block presynaptic sodium channels on the nerve terminal itself. This interferes with the mobilization of acetylcholine for release.
So it affects acetylcholine release too?
It can, yes. And this causes a characteristic phenomenon known as fade of evoked nerve twitch contractions during monitoring. This fade is a critical monitoring parameter in clinical practice, telling us about the depth of the block.
Okay.
Another key principle here is the surmountable nature of the postsynaptic blockade produced by these drugs. If you apply tetanic stimulation, that's a rapid series of strong electrical stimuli to a peripheral nerve, it causes a large quantity of acetylcholine to be released.
A big flood of acetylcholine.
Right. And this surge of neurotransmitter can temporarily overcome the blockade, leading to a transient increase in twitch strength known as post-tetanic facilitation.
So the block can be temporarily overcome.
Yes, and this phenomenon is clinically significant because it forms the basis for how cholinesterase inhibitors can effectively reverse residual blockade at the end of surgery by increasing ACE levels enough to compete off the blocker.
That's incredibly precise. So how does succinylcholine, the depolarizing drug, create its unique block? It's almost like a paradox, an agonist causing a block.
Indeed, it is a paradox, and understanding it requires distinguishing between two phases of blockade with succinylcholine. First, we have phase I block, the depolarizing phase.
I, okay.
Succinylcholine is the only clinically useful depolarizing blocking drug. Its effects at the myoneural junction are similar to acetylcholine in that it binds to the nicotinic receptor and opens the ion channel. But crucially, succinylcholine produces a much longer effect because it's not effectively metabolized right there at the synapse like acetylcholine is.
It sticks around longer.
Much longer. Here's what happens. Succinylcholine reacts with the nicotinic receptor to open the ion channel and cause a continuous depolarization of the motor end plate. This depolarization then spreads to the adjacent muscle membranes, initially causing those transient, disorganized muscle contractions, which we call fasciculations.
The muscle twitches.
Right. But because succinylcholine persists in the synapse, the depolarized membranes remain depolarized and consequently become unresponsive to subsequent nerve impulses. The sustained depolarization prevents the muscle from repriming or repolarizing, which is essential for repetitive firing and maintaining muscle tension. The result is a flaccid paralysis.
So it paralyzes by keeping the muscle switched on but unresponsive.
That's a good way to think about it. And this is a critical distinction from non-depolarizing drugs. A phase I block is augmented, not reversed, by cholinesterase inhibitors.
Why is that?
Because increasing acetylcholine with a cholinesterase inhibitor would only intensify the sustained depolarization, making the block worse.
Ah, so you absolutely do not want to try reversing a phase I succinylcholine block with neostigmine.
Absolutely not. It highlights how fundamentally different these two mechanisms are. Trying to reverse it will actually make things worse.
Okay, critical takeaway. What about phase II?
Right. Now, if there's prolonged exposure to succinylcholine, the blockade can transition into phase II block, sometimes called the desensitizing phase.
Phase II desensitized.
Yes. In this phase, the initial end plate depolarization gradually decreases, and surprisingly, the muscle membrane actually repolarizes.
This goes back to normal voltage.
It repolarizes, yes. However, despite this repolarization, the membrane cannot easily be depolarized again because it has become desensitized. The exact molecular mechanism for this desensitizing phase isn't entirely clear, but the channels behave as if they are in a prolonged closed state, even though the membrane potential is back to normal.
So it's repolarized but still unresponsive. Weird.
It is complex. What's clinically challenging about phase II is that later in its development, the characteristics of the blockade become nearly identical to those of a non-depolarizing block.
It starts to look like a non-depolarizing block.
Exactly. For instance, you'll observe a non-sustained twitch response to a tetanic stimulus, that fade we talked about, similar to what you see with non-depolarizing agents. And critically, the blockade may even become partially reversible by acetylcholinesterase inhibitors.
Whoa, so it could be confusing clinically.
It can create a challenging diagnostic scenario in practice if you don't know the patient's history of succinylcholine administration. You might think it's a non-depolarizing block when it's actually a phase 2 succinylcholine block, requires careful clinical judgment.
That's an incredibly deep dive into the mechanisms. So moving to the practical side, how do clinicians actually use and monitor these powerful drugs in a real-world setting, like during surgery?
Clinically, yeah, the primary benefit of neuromuscular blocking drugs is enabling that profound skeletal muscle paralysis without needing dangerously deep general anesthesia.
We keep coming back to that safety aspect.
It's fundamental. Historically, before these drugs, surgeons could only achieve the muscle relaxation needed for complex operations by using volatile anesthetics at levels that severely depress the patient's cardiovascular and respiratory systems. The adjunctive use of neuromuscular blockers completely changed that, allowing adequate muscle relaxation for all types of surgical procedures while maintaining safer cardiorespiratory function.
Okay. How does the paralysis typically progress?
The general pattern of paralysis onset is initial motor weakness, quickly followed by flaccid, inexcitable muscles. An important concept here is differential muscle susceptibility.
Meaning different muscles react differently.
Exactly. Larger muscles, such as those in the abdomen, the trunk, and critically the diaphragm, are generally more resistant to neuromuscular blockade and tend to recover more rapidly than smaller muscles, like those in the face or hand.
Interesting. So the diaphragm is tougher to paralyze.
Yes, the diaphragm, the primary muscle of breathing, is usually the last muscle to be paralyzed and, critically, the first to regain function when the muscle relaxant is discontinued.
That's good for safety, I guess.
It is. For instance, an older drug like d-tubocurarine typically lasts 45-60 minutes, but subtle residual paralysis can persist for another hour, increasing risks like aspiration or decreased hypoxic drive.
Residual paralysis is a concern then.
Definitely. Now, among the currently available non-depolarizing drugs, rocuronium stands out for its rapid onset time, typically between 60 and 120 seconds.
Rocuronium is fast.
Very fast for a non-depolarizer. This speed is absolutely critical for rapid sequence intubation, where securing the airway quickly is paramount.
And succinylcholine, even faster.
Even swifter, yes. Succinylcholine as a depolarizing agent causes rapid paralysis, usually within 90 seconds, often preceded by those transient muscle fasciculations. But as we discussed, due to its rapid hydrolysis, its block typically lasts less than 10 minutes.
That swift action is clearly a huge advantage sometimes. But how do clinicians actually know how much paralysis has been achieved? You can't just guess with something this potent.
You absolutely cannot guess. Assessment of neuromuscular transmission is crucial. It's vital for ensuring adequate relaxation during surgery and, equally important, for guaranteeing a safe and complete recovery afterwards.
How is it done?
This monitoring typically involves using a device, a peripheral nerve stimulator, that delivers transdermal electrical stimulation to one of the patient's peripheral nerves. Usually it's a nerve in the hand that controls thumb movement, like the ulnar nerve, or sometimes a facial nerve. The clinician then observes or records the evoked muscle contractions, the twitch responses.
Watching the twitches. Okay. What patterns do they look for?
There are several key monitoring patterns. The three most commonly used are, first, single twitch stimulation. Here, a single supramaximal electrical stimulus is applied at low frequencies, maybe 0.1 Hz to 1.0 Hz, just to determine peak drug effect or confirm a baseline response.
Okay, simple enough. What's next?
Second, and perhaps the most common, is train of 4 TOF stimulation.
Train of 4, TOF. Heard of that.
Right. This involves 4 successive supramaximal stimuli given at intervals of 0.5 seconds, which is 2 Hz. The key measure here is the relative magnitude of the response of the fourth twitch compared with the first twitch, calculated as the TOF ratio.
How does the ratio change with different blocks?
Good question. With a depolarizing block, like succinylcholine in phase I, all 4 twitches are reduced proportionally, but the ratio between them stays pretty constant, close to 1.0.
Okay. And non-depolarizing?
With a non-depolarizing block, the TOF ratio decreases. We call this characteristic decrease fade. The amount of fade is inversely proportional to the degree of blockade. The deeper the block, the more fade, the lower the ratio.
So fade indicates a non-depolarizing block.
Correct. And as the patient recovers, the amount of fade decreases and the TOF ratio approaches 1.0 again, Clinically, a TOF ratio greater than 0.9 is generally considered necessary for complete clinical recovery and safe extubation.
zero point 0.9 or higher for safety. Got it. What about succinylcholine phase 2?
Good point. It's worth noting that if you see fade in the TOF response after administering succinylcholine, it signifies the development of a phase 2 block, indicating that the initial depolarizing block has transitioned into that desensitizing phase.
So fade with succinylcholine means phase 2. Okay. What's the third pattern?
Third is tetanic stimulation. This involves a very rapid delivery of electrical stimuli, typically 30 to 100 hertz, for several seconds.
Really fast pulses.
Very fast. Now, during a non-depolarizing block, and also during a phase 2 block from succinylcholine, the muscle response to this tetanic stimulation is not sustained, and again, fade of the twitch responses is observed. This fade is primarily considered a presynaptic event, reflecting an impact on acetylcholine release, but it correlates well with the depth of blockade.
Okay. And didn't you mention post-tanic facilitation earlier?
Yes. A fascinating aspect of partial non-depolarizing blockade is post-tanic facilitation. After a brief tetanic nerve stimulation, you'll often see an increase in the post-tanic twitch response, essentially a transient relief of the blockade.
Temporary boost in strength.
Exactly. And for very deep blockade, where there might be no response even to tetany, clinicians can use something called a post-tetanic count, PTC. This involves applying 5 seconds of 50 Hz tetany followed by 3 seconds of rest, and then applying 1 Hz pulses. The number of detectable muscle twitches after the tetanus gives an estimation of the depth of the blockade and helps predict recovery time.
Wow, quite technical. Any other monitoring techniques?
There's also double burst stimulation. This was developed to make it easier for clinicians to manually feel for residual neuromuscular blockade when looking at the twitches is difficult. It's often easier to detect subtle fade with double burst stimulation than with TOF, helping confirm the absence of clinically significant residual blockade. For more precise measurement, you can use a force transducer attached to the thumb to get a quantitative graphic display of the twitch force and fade.
That's a lot more complex than I imagined. Beyond the muscles themselves, do these drugs have significant effects on other body systems like the heart or blood pressure? Safety concerns there.
They absolutely can, yeah. And these are critical considerations for patient safety. Interestingly, some of the newer, more commonly used non-depolarizing muscle relaxants like vecuronium, cisatracurium, and rocuronium actually have minimal, if any, cardiovascular effects.
So those ones are pretty safe heart-wise.
Generally, yes. They offer good cardiovascular stability. However, older agents and some others can have a more significant impact. For example, d-tubocurarine and, to a lesser extent, atracurium can cause hypotension or low blood pressure.
Why is that?
This is primarily due to systemic histamine release from mast cells, which causes vasodilation, relaxing the blood vessels. D-tubocurarine at higher doses can also cause ganglionic blockade, further contributing to a drop in blood pressure.
Okay. What about pancuronium?
Pancuronium has a unique cardiovascular effect. It causes a moderate increase in heart rate and a smaller increase in cardiac output, with little change in systemic vascular resistance.
Increases heart rate. How?
This is primarily due to its vagolytic action, meaning it blocks the vagus nerve's normal inhibitory effects on the heart, letting the heart rate drift up. There might be secondary mechanisms involving norepinephrine, too.
Okay. And succinylcholine. It seems to have unique effects elsewhere, too.
It does. Succinylcholine, as the lone depolarizing agent, has quite complex cardiac effects. It can cause cardiac arrhythmias, especially when administered during halothione anesthesia. The drug stimulates various autonomic cholineceptors, nicotinic ones at ganglia, muscarinic ones in the heart sinus node.
So it can affect heart rhythm.
Yes, it can lead to negative inotropic and chronotropic responses, meaning a decrease in the force of heart contraction and heart rate. A very notable and repeatedly observed phenomenon is bradycardia, a slowed heart rate, especially when a second dose of succinylcholine is given less than 5 minutes after the initial dose.
Repeat doses cause bradycardia. Okay, can that be prevented?
Yes, this transient bradycardia can often be prevented or attenuated by pre-treating with anticholinergic drugs like atropine or glycopyrrolate.
That's a lot to keep track of. Are there other significant adverse effects, particularly with succinylcholine, given its unique mechanism? Seems like it causes more issues.
Yes, there are several, and some are very serious. One of the most critical risks associated with succinylcholine is hyperkalemia.
High potassium, right. Why does that happen?
In certain patient populations, specifically those with severe burns, extensive nerve damage, pre-existing neuromuscular disease, closed head injury, or other major trauma, there can be a significant proliferation of those extrajunctional acetylcholine receptors we discussed earlier.
The ones that multiply.
Exactly. When succinylcholine is administered to these patients, it causes a massive sustained depolarization and fasciculations, which leads to a significant release of potassium ions from inside the muscle cells into the bloodstream.
And high potassium is dangerous for the heart.
Extremely dangerous. If this potassium release is great enough, it can lead to severe cardiac arrhythmias, even cardiac arrest. Therefore, it is standard, best clinical practice to avoid the use of succinylcholine entirely in these known high-risk cases.
Okay, critical safety point. What else?
Another adverse effect is an increase in intraocular pressure. Succinylcholine can cause a rapid onset of increased pressure within the eye, typically peaking within a few minutes. This is thought to involve tonic contraction of tiny eye muscles or maybe transient dilation of blood vessels in the eye.
So, problematic for eye surgery.
Generally, it's not contraindicated for most ophthalmologic operations unless the anterior chamber of the eye is open, like in a penetrating injury, a condition referred to as open globe.
Okay. What else?
We also see increased intragastric pressure. The fasciculations that occur with succinylcholine, especially in heavily muscled patients, can cause an increase in pressure within the stomach.
And that increases aspiration risk.
Significantly increases the risk for regurgitation and aspiration of gastric contents into the lungs, which can be a life-threatening complication. This risk is higher in patients who already have delayed gastric emptying, such as those with diabetes, trauma, or obesity.
Okay, one more.
Finally, a common post-operative complaint, particularly in heavily muscled patients or those who receive larger doses of succinylcholine, is muscle pain or myalgias.
Why the pain?
The pain is believed to be secondary to the unsynchronized, intense contractions of adjacent muscle fibers, those fasciculations that occur just before the onset of complete paralysis.
That's quite the list of potential problems with succinylcholine. Given how powerful these drugs are overall, how do they play with other medications? Is it a pharmacological minefield out there?
It can certainly be complex, yeah, and understanding these interactions is crucial for safe practice. Let's start with anesthetics. Inhaled or volatile, anesthetics significantly potentiate, meaning they enhance the neuromuscular blockade produced by non-depolarizing muscle relaxants.
So the anesthetic makes the blocker stronger.
Yes, in a dose-dependent fashion. The deeper the anesthesia with volatile agents like isoflurane or sevoflurane, the greater the muscle relaxation you get from a given dose of a non-depolarizing blocker. This augmentation occurs due to several factors, including depression of the central nervous system, increased blood flow to muscles, and maybe decreased sensitivity of the postsynaptic membrane.
Okay, what about that malignant hyperthermia link?
Right. A very rare but extremely critical interaction is the combination of succinylcholine with volatile anesthetics triggering malignant hyperthermia in susceptible individuals.
The hereditary condition.
Exactly. It's that abnormal release of calcium from stores within skeletal muscle, leading to a massive increase in body temperature and muscle rigidity. It's a true medical emergency, treated specifically with dantrolene.
Okay. What about antibiotics?
Moving to antibiotics, numerous reports describe their ability to enhance neuromuscular blockade. Aminoglycosides, like gentamicin, for example, have been shown to depress the evoked release of acetylcholine from the nerve terminal, probably by blocking certain calcium channels. This makes the neuromuscular blockade more profound or longer lasting.
So, need to be careful combining those.
Definitely. Even local anesthetics and antiarrhythmic drugs can interact. In small doses, local anesthetics can subtly depress nerve function. In larger doses, they can directly block neuromuscular transmission by physically blocking the nicotinic receptor ion channels. Experimentally, similar effects can be demonstrated with sodium channel blocking antiarrhythmic drugs like quinidine, though generally at therapeutic doses for cardiac arrhythmias, this interaction isn't usually clinically significant. Bupivacaine, a local anesthetic, has its own separate links to cardiac issues.
I recall something about precurization or using one muscle relaxant to affect another. Is that still a common practice?
You're referring to the historical practice where a small, non-paralyzing dose of a non-depolarizing blocker, like rocuronium, would be given before administering succinylcholine.
Yeah, why was that done?
The idea was to prevent or reduce succinylcholine's initial muscle fasciculations and the associated postoperative myalgias.
Did it work?
It could reduce fasciculations, yes, but it also significantly increased the amount of succinylcholine needed to achieve adequate relaxation for intubation, sometimes by 50–90%. Plus, it could cause an unpleasant feeling of weakness or difficulty swallowing in awake patients before the anesthesia started.
So not ideal.
Not ideal. Consequently, routine precurization before succinylcholine is no longer widely practiced due to these significant downsides.
Makes sense. Beyond drug interactions, how do certain diseases and aging affect how patients respond to these blockers?
Patient factors are hugely important. For instance, myasthenia gravis, that autoimmune neuromuscular disease, actually enhances the neuromuscular blockade produced by non-depolarizing relaxants.
So patients with MG are more sensitive.
Much more sensitive. This means patients with myasthenia gravis will require much lower doses of these drugs, and careful monitoring is essential.
Okay. What about older patients?
In advanced age, specifically in patients perhaps over 70 years, you typically see a prolonged duration of action from non-depolarizing relaxants.
They last longer in the elderly. Why?
It's mainly due to decreased clearance of the drugs by the liver and kidneys, which naturally happens as part of aging. As a result, the dosage of neuromuscular blocking drugs should generally be reduced in older patients to prevent prolonged paralysis and ensure timely recovery.
Okay, reduced dose for older patients. What about the opposite resistance?
Conversely, and this is a fascinating counterpoint, patients with severe burns and those with upper motor neuron disease, like from a spinal cord injury, are often resistant to non-depolarizing muscle relaxants.
Resistant. They need more drug.
Yes, significantly more sometimes. This desensitization is probably caused by that significant proliferation of extrajunctional acetylcholine receptors we talked about earlier. Because there are so many more receptors spread over the muscle membrane, it requires an increased dose of the non-depolarizing relaxant to block a sufficient number of them to achieve the desired effect.
Wow. So the same conditions that make succinylcholine dangerous due to hyperkalemia make patients resistant to non-depolarizing blockers.
Exactly. Understanding these nuances is absolutely key to safe patient management and truly showcases an elite professional's grasp of this complex interplay.
That's a huge amount of information for clinicians to integrate for each patient. So once the surgery is over, or the need for paralysis is done, how do you bring patients back? How is this profound neuromuscular blockade reversed safely?
Reversing neuromuscular blockade is just as critical as inducing it, especially with the non-depolarizing drugs, to ensure the patient can breathe effectively on their own and protect their airway. There are two main strategies for reversal.
Okay, strategy one.
The first and more traditional approach involves using cholinesterase inhibitors. The common ones are neostigmine, pyridostigmine, and edrophonium.
How do they work?
These drugs primarily antagonize or reverse the non-depolarizing blockers by increasing the availability of acetylcholine at the motor end plate.
By stopping its breakdown.
Primarily, yes. They achieve this mainly by inhibiting the enzyme acetylcholinesterase, which normally breaks down Ang. By preventing aortate breakdown, they allow more acetylcholine to accumulate at the synapse. This increased concentration of aortate then has a better chance of successfully competing with the blocking drug for the nicotinic receptors, kicking the blocker off and reactivating muscle contraction.
So it's a numbers game, more 80s wins.
Essentially, yes. To a lesser extent, neostigmine and pyridostigmine also increase the release of acetylcholine from the motor nerve terminal itself. Edrophonium tends to have a more rapid onset, but might be less effective in reversing very deep neuromuscular blockade compared to neostigmine.
And preventing residual block is key.
Absolutely critical. Preventing residual block, any lingering blockade after surgery, is clinically paramount. Even small amounts can lead to problems like hypoventilation, hypoxia, airway obstruction, and even apnea, especially if patients have also received central depressant medications like opioids postoperatively.
Okay, that's the traditional way. What's the second strategy? You mentioned sugammadex earlier.
Right. The second and much more recent strategy is the use of sugammadex.
Ah, sugammadex. I've heard this described as a game changer for reversing paralysis, especially from certain blockers. What makes it so revolutionary?
It truly is a game changer, particularly for the steroid-based blockers. Sugammadex is a breakthrough reversal agent specifically approved for the rapid reversal of the neuromuscular blockade induced by the steroid neuromuscular blocking agents, primarily rocuronium and, to a lesser extent, vecuronium.
Okay. What makes it unique? How does it work?
What makes sugammadex unique is its truly novel mechanism of action. It's a modified gamma-cyclodextrin. Think of it as a large, ring-shaped molecule with a hydrophobic core and a hydrophilic exterior.
A molecular donut.
Kind of. Its unique structure allows it to bind tightly and very specifically to rocuronium and vecuronium molecules in a 1:1 ratio directly in the plasma. Imagine it like a molecular cage or chelation agent that specifically encapsulates the rocuronium molecule.
So it traps the drug in the blood.
Exactly. By binding to rocuronium in the plasma, sugammadex effectively decreases the free plasma concentration of the muscle relaxant. This creates a powerful concentration gradient that literally pulls rocuronium away from the neuromuscular junction, where it's causing paralysis, back into the circulation.
Pulls it right off the receptor.
Well, it pulls it out of the synapse and into the plasma as the free concentration drops. Once in the circulation, the rocuronium is quickly bound by any free sugammadex molecules. This is a remarkably elegant and completely distinct mechanism compared to cholinesterase inhibitors, which act on enzymes. Sugammadex simply removes the drug from the equation by binding it up.
That sounds much more direct. Does it work faster?
Clinically, this translates into remarkably rapid reversal, much faster than neostigmine, especially for deep blockade. There are 3 recommended dose ranges for sugammadex, depending on the depth of the blockade being reversed. 2 milligrams for shallow blockade, like 2 twitches visible on TOF. 4 milligrams for deeper blockade, when you only see post-tetanic counts. And a higher dose of 16 milligram for immediate reversal following a single high intubating dose of rocuronium.
16 milligram for immediate reversal. How fast is that?
With that dose, reversal can occur within a mere 1.5 to 3.0 minutes, which is absolutely critical in emergency situations like a can't intubate, can't ventilate scenario.
Wow, that's incredibly fast. How is it eliminated?
In terms of elimination, the sugammadex rocuronium complex is typically excreted unchanged in the urine, usually within 24 hours in patients with normal renal function.
Okay, but what about patients with kidney problems?
That's a crucial consideration. In patients with renal insufficiency, the plasma half-life of sugammadex increases significantly. In severe renal impairment, like a creatinine clearance less than 30 mmol, it can be extended dramatically, up to maybe 19 hours.
So it hangs around much longer.
Much longer. While some studies suggest it may be dialysable, meaning it could be removed by dialysis, it is generally not recommended for use in patients with severe renal impairment unless absolutely necessary, due to the prolonged presence of the drug and its complex. This is a critical safety consideration for you to remember.
Got it. Are there other significant side effects or risks with sugammadex?
Yes, it's associated with a few significant adverse reactions, particularly at higher doses. Most importantly, it can cause anaphylaxis, a severe, potentially life-threatening allergic reaction. Although rare, it highlights a small but serious risk.
Anaphylaxis, okay.
Yeah.
Anything else?
More common are other hypersensitivity reactions like nausea, pruritus, which is itching, and urticaria hives. Other significant adverse reactions that have been reported include marked bradycardia, a very slow heart rate, which can sometimes progress rapidly to cardiac arrest within minutes of administration, and also a temporary coagulopathy, which is an effect on blood clotting specifically, about a 25% elevation of activated partial thromboplastin time, APTT, and prothrombin time international normalized ratio, PTINR values, which typically lasts for up to an hour after the dose.
Bradycardia and clotting issues too. Okay.
Another fascinating and clinically important aspect of sugammadex is its drug interactions, specifically its ability to bind other steroidal drugs beyond just rocuronium and vecuronium.
Binds other steroids. Like what?
Given that it binds to rocuronium and vecuronium, which are steroid-based muscle relaxants, this isn't entirely surprising. The 2 most important interactions involve progesterone-based contraceptives and the selective estrogen receptor modulator teramifene.
Wait, it affects birth control pills?
Yes. When sugammadex is given to a woman taking hormonal contraceptives that contain progesterone, the sugammadex can bind to the progesterone molecule itself. This binding decreases the efficacy of the contraceptive, essentially making it as if the woman missed 1 or 2 doses of her pill.
Wow, that's a huge deal.
It absolutely is. The manufacturer strongly recommends that an alternative non-hormonal contraceptive method, like condoms, be used for the following 7 days after receiving sugammadex. This is a vital patient counseling point that must be communicated.
Definitely. And the other drug interaction.
It also tightly binds tormemifene, a drug sometimes used to treat metastatic breast cancer. This interaction can potentially reduce the efficacy of tormemifene. Also, theoretically, tormemifene could displace rocuronium from sugammadex, potentially leading to a recurrence or prolongation of neuromuscular blockade.
Wow, that contraceptive interaction is something you absolutely would not think of offhand. Okay, so beyond the operating room and reversal, what are the other key uses for these potent neuromuscular blocking drugs?
Beyond the OR, these drugs have several crucial applications. Of course, surgical relaxation remains paramount, facilitating complex intracavitary procedures inside the abdomen or chest by providing that perfectly still and relaxed surgical field.
Right.
Second, and equally vital, is their use in endotracheal intubation. By relaxing the muscles of the pharynx and larynx, neuromuscular blocking drugs facilitate laryngoscopy and the smooth, safe placement of an endotracheal tube. This ensures an adequate airway for breathing and critically minimizes the risk of pulmonary aspiration of gastric contents during general anesthesia.
Essential for airway management.
Absolutely. Third, they are used quite frequently for control of ventilation in critically ill patients, particularly in the intensive care unit. ICU.
In the ICU. Why?
For patients suffering from severe ventilatory failure due to conditions like severe bronchospasm, like in asthma or COPD, pneumonia, or ARDS, acute respiratory distress syndrome, it may be necessary to completely control their ventilation with a mechanical ventilator. Neuromuscular blocking drugs are often administered in the ICU in these situations to reduce chest wall resistance, thereby improving lung compliance, decreasing oxygen utilization by the respiratory muscles as they aren't working against the ventilator, and improving overall synchrony between the patient and the mechanical ventilator.
Helps the ventilator do its job better.
Essentially, yes. Finally, succinylcholine specifically is occasionally used in the treatment of convulsions.
Treating seizures. But you said they don't cross the blood-brain barrier.
Exactly. It has no effect on the central electrical activity of a seizure because it does not cross the blood-brain barrier. However, it is effective in attenuating or eliminating the peripheral or motor manifestations of convulsions, the shaking.
Stops the physical seizing.
Correct. This can be important in managing patients during status epilepticus or following local anesthetic toxicity, or perhaps most commonly during electroconvulsive therapy, ECT, for psychiatric conditions, to prevent severe muscle damage and potential injury to the patient during the seizure activity itself. 3. Spasmolytic and antispasmodic drugs, restoring movement and relieving pain.
Okay, let's shift gears completely now. We've spent a lot of time on the acute controlled paralysis needed for surgery and critical care. Now let's talk about the chronic, often debilitating conditions of muscle spasm and spasticity. This is a very different kind of challenge, isn't it?
It is indeed a fundamentally different set of challenges, requiring a distinct pharmacological approach. While both categories aim to relax muscles, the underlying causes and the mechanisms they target are vastly different.
So how should we categorize these?
When we talk about these drugs, it's important to distinguish between spasmolytics, which primarily treat spasticity, often resulting from upper motor neuron lesions, damage to the brain, or spinal cord pathways.
Okay, spasmolytics for spasticity.
And antispasmodics, which are generally used to treat acute muscle spasms arising from peripheral musculoskeletal conditions, like a muscle strain or injury.
Got it. Spasmolytics for central issues, antispasmodics for local muscle problems.
Broadly speaking, yes. Let's first unpack spasticity. How does it present? Well, it's characterized by intermittent or sustained involuntary contraction of skeletal muscle. This leads to stiffness that can significantly interfere with mobility, speech, and overall function.
Sounds debilitating.
It can be very debilitating. It's characterized by an increase in tonic stretch reflexes, meaning muscles resist being stretched more than they should, and also flexor muscle spasms, which contribute to an increased basal muscle tone. All of this often occurs alongside underlying muscle weakness.
What causes spasticity?
It's commonly associated with a variety of neurological conditions, including spinal cord injury, cerebral palsy, multiple sclerosis, MS, and stroke.
Okay, what's happening neurologically?
The neurological mechanisms underlying clinical spasticity are pretty complex. They involve not just the local stretch reflex arc in the spinal cord itself, but also higher centers in the central nervous system. Damage to descending inhibitory pathways in the spinal cord, for instance, seems to lead to a hyperexcitability of the alpha motor neurons, the nerves that directly tell muscles to contract in the spinal cord.
So loss of inhibition leads to overactivity.
That's a key part of it, yes. The pharmacological approach to treating spasticity aims to modify this hyperactive stretch reflex arc. This can be done either by modulating excitatory or inhibitory synapses in the spinal cord, or, in some cases, by directly interfering with the skeletal muscle's excitation-contraction coupling process itself.
What's the challenge in treating it?
The challenge is really balancing the reduction of muscle hyperactivity without inadvertently reducing desired normal muscle function or causing too much weakness or sedation. And while current drugs can provide significant relief from painful spasms associated with spasticity, it's important for the listener to note that they are often less effective in improving meaningful function, like overall mobility or enabling someone to return to work. The relief is often symptomatic.
Okay, so let's look at some of these specific spasmolytic drugs that target the central nervous system. Diazepam is a familiar name to many. Valium.
Yes, diazepam as a benzodiazepine works by facilitating the action of GABA, the main inhibitory neurotransmitter in the central nervous system. It specifically enhances the effect of GABA at GABA receptors.
Works on GABA.
Right. Its action in reducing spasticity is at least partly mediated in the spinal cord, as it can even be somewhat effective in patients who have had a complete spinal cord transection.
Okay, what's it used for?
While diazepam can be used for muscle spasm of almost any origin, including localized muscle trauma, its primary limitation in treating spasticity is that it produces significant sedation at the doses required to effectively reduce muscle tone.
The sedation is the main drawback.
It's a major drawback for chronic use, yeah. The initial dosage typically starts around 4 milligrams per day and can be gradually increased, sometimes up to a maximum of 60 milligrams per day, balancing effect against sedation.
Okay. What about meprobamate and carisoprodol? So Soma is the brand name for carisoprodol.
Right. Meprobamate and carisoprodol are essentially sedatives that have also been marketed and used as central muscle relaxants. However, a key issue with these drugs is the lack of strong evidence for their efficacy, specifically as muscle relaxants, without also causing significant sedation.
So maybe they just make you sleepy, and that helps the muscle pain.
That's likely a large part of their perceived effect, yes. And there are significant risks. Carisoprodol is actually metabolized in the body to meprobamate. Both are classified as Schedule IV controlled substances in the U.S., indicating their potential for abuse and dependence.
Abuse potential, yes.
And here's a significant risk. After extensive use, abruptly stopping carisoprodol or meprobamate can elicit a severe physical withdrawal syndrome. This can include anxiety, tremors, muscle twitching, insomnia, and even auditory and visual hallucinations.
Wow, serious withdrawal.
It highlights a serious safety concern, particularly with prolonged use or misuse.
That's a strong warning. What about baclofen? That's another common one, often used with a more severe spasticity, maybe an MS or spinal cord injury?
Yes, baclofen, or chlorophenyl GABA, was specifically designed as an orally active GABA mimetic agent. It functions as an agonist primarily at GABA receptors, which are distinct from the GABA receptors targeted by benzodiazepines.
Okay, GABA agonist. How does that work?
Its mechanism of action is quite intricate. Activation of these GABA receptors by baclofen results in hyperpolarization of neurons, making them less likely to fire. It achieves this through 3 distinct actions. First, it causes the closure of presynaptic calcium channels, reducing neurotransmitter release. Second, it increases postsynaptic potassium conductance, letting positive charge leave the cell. And third, it inhibits dendritic calcium influx channels.
Okay, multiple inhibitory actions.
Right. These combined actions lead to a reduced release of excitatory neurotransmitters like glutamate in both the brain and the spinal cord. This effectively suppresses the activity of ES sensory afferents coming from muscle spindles, as well as spinal interneurons and the alpha motor neurons themselves.
So it dampens down that whole hyperactive reflex loop.
Exactly. Baclofen may also offer some pain relief in patients with spasticity, possibly by inhibiting the release of substance P in the spinal cord, which is a key neurotransmitter involved in pain signaling.
How does it compare clinically to diazepam?
Clinically, baclofen is generally considered at least as effective as diazepam and another drug, tizanidine, in reducing spasticity. A key advantage is that it is notably less sedating than diazepam at doses that provide similar spasm relief.
Less sedation is good. Any effect on strength?
It also has the advantage of not reducing overall muscle strength as much as dantrolene, which we'll get to, and that's important for preserving patient function.
Okay. How is it taken and handled by the body?
Pharmacokinetically, it's rapidly and completely absorbed after oral administration with a plasma half-life of around 3-4 hours. Dosing typically starts low, maybe 15 milligrams twice daily, and can be gradually increased as tolerated, sometimes up to 100 milligrams daily, depending on the response and side effects.
Is it only given orally?
No, and this is very important. A very significant application of baclofen is its intrathecal administration.
Intrathecal, directly into the spinal fluid.
Exactly. This involves direct delivery of the drug into the cerebrospinal fluid via a surgically implanted catheter connected to a programmable pump. This route is reserved for patients with severe spasticity and associated muscle pain that are unresponsive to maximum doses of oral medications.
Why deliver it that way?
Because baclofen doesn't cross the blood-brain barrier very well, and it also has poor egress from the spinal cord once it's in there. Delivering it intrathecally allows much higher concentrations to be achieved directly in the spinal cord where it's needed, while minimizing systemic exposure and thus peripheral side effects like sedation or weakness.
So better effect with fewer side effects.
Potentially, yes. Long-term intrathecal baclofen therapy can profoundly improve the quality of life for many patients with severe spastic disorders. However, it does come with significant disadvantages.
Such as?
Primarily related to the maintenance of the pump and catheter system, there can be malfunctions, infections, catheter issues, and also there's the serious risk of an acute withdrawal syndrome if the treatment is suddenly interrupted, perhaps due to catheter failure or running out of drug in the pump. This withdrawal can be life-threatening, involving rebound spasticity, fever, altered mental status, and seizures.
Wow, abrupt withdrawal is dangerous.
Extremely dangerous. Partial tolerance to the drug's effect may also occur over several months of continuous infusion. High doses of baclofen, whether oral or especially from intrathecal pump malfunction, can cause excessive somnolence, respiratory depression, and even coma. Patients with epilepsy may experience increased seizure activity. It's imperative that withdrawal from baclofen, especially intrathecal, is done very, very slowly under medical supervision.
Okay. Any other uses for baclofen being explored?
Interestingly, yes. Oral baclofen has been investigated, sometimes with anecdotal success, for a wide variety of other conditions, things like intractable low back pain, stiff person syndrome, trigeminal neuralgia, cluster headache, intractable hiccups, fistutic disorders, even GERD, gastroesophageal reflux disease, and reducing cravings for alcohol, nicotine, and cocaine.
Quite a list. Are these uses well established?
It's important to note that for many of these potential uses, its efficacy has not been definitively established through large, rigorous clinical trials. And specifically for spasticity, oral baclofen hasn't shown clear benefit in conditions like stroke, Parkinson's disease, or cerebral palsy.
Okay, that's quite a wide range of potential uses, even if not all are established. What about tizanidine? That's another one I've heard used frequently, maybe as an alternative to baclofen.
Yes, tizanidine is another key spasmolytic drug. It's structurally related to clonidine, an older blood pressure medication, and is classified as an alpha-2 adrenoceptor agonist.
Alpha-2 agonist, how does that help spasticity?
It has significant alpha-2 agonist effects, primarily in the spinal cord. It's believed to reduce spasticity by reinforcing both presynaptic and postsynaptic inhibition in the spinal cord, essentially calming down the overactive motor pathways. It also seems to inhibit nociceptive pain transmission in the spinal dorsal horn.
So it affects both spasm and pain signals.
Potentially, yes. What makes it clinically notable is that it reduces spasticity at doses that cause fewer cardiovascular effects, particularly less hypotension, than clonidine. It has roughly 1/10 to 1/15 of clonidine's blood pressure lowering effect.
Less impact on blood pressure is good. How does its efficacy compare?
In clinical trials, oral tizanidine has shown comparable efficacy in relieving muscle spasm to diazepam, baclofen, and dantrolene. A significant advantage reported is that it causes markedly less muscle weakness than some other agents, which is beneficial for function.
Less weakness is a plus. What about side effects?
It presents a different spectrum of adverse effects compared to baclofen or diazepam. Common ones include drowsiness, hypotension, which can still occur in maybe 16-33% of patients, dizziness, dry mouth, and asthenia, a feeling of weakness or lack of energy. Importantly, it can also cause hepatotoxicity or liver damage.
Liver toxicity, so monitoring is needed.
Yes, this risk necessitates regular monitoring of liver function tests as well as blood pressure and renal function, especially when starting the drug or increasing the dose. Drowsiness can often be managed by taking the dose at night.
How is it dosed?
Tizanidine exhibits linear pharmacokinetics, but the dosage requirements can vary considerably between individuals. It's usually initiated at a low dose, maybe 2 milligrams every 6 to 8 hours, and gradually increased up to a maximum of 36 milligrams per day based on response and tolerability. Dosage adjustment is needed in patients with hepatic or renal impairment.
Any drug interactions?
Yes, its plasma levels can be significantly increased if taken with drugs that inhibit the liver enzyme CYP1A2. And like baclofen, there's a critical warning. Abrupt withdrawal of tizanidine should be strictly avoided as it can lead to rebound hypertension, tachycardia, and increased muscle spasms. It needs to be tapered off slowly. It's also sometimes used off-label for chronic migraine prevention.
Okay. What about other centrally acting spasmolytic drugs? Are there more in this category?
Yes, there are several others, though perhaps less extensively studied or used or with more specific niches. Gabapentin, Neurontin, an anti-epileptic drug, has shown considerable promise as a spasmolytic agent in studies involving patients with multiple sclerosis.
Gabapentin for MS spasticity.
Yes. And pregabalin, Lyrica, a newer analog of gabapentin, may also be useful for painful disorders that involve muscle spasm. Preliminary studies have also explored progabide, an experimental GABA agonist, and glycine, an inhibitory amino acid neurotransmitter, for reducing spasticity. Newer drugs approved for amyotrophic lateral sclerosis, ALS, like idursulfide and riluzole, also appear to have some spasm-reducing effects, possibly by inhibiting glutamatergic transmission in the CNS or stabilizing voltage-dependent sodium channels.
Okay, a few others in the pipeline are with niche uses. Now let's talk about the direct-acting muscle relaxants. This sounds like they're not working on the nervous system at all, but directly on the muscle itself. And everyone knows Botox, so let's start there. Botulinum toxin. How does that work to relax muscles beyond just smoothing wrinkles?
You're right. Botulinum toxin, or BoNT, is classified as a direct-acting muscle relaxant, but its mechanism is profoundly different from the others we've discussed. This isn't a systemic drug you take orally. It's a neurotoxin that produces chemodenervation, basically, a chemical disruption of nerve function and local paralysis when injected directly into a specific muscle or group of muscles.
Chemodenervation.
Okay.
Let's deep dive into its mechanism. How does it stop the muscle?
Okay. The single-chain polypeptide BoNT molecule is actually inactive until it's cleaved inside the nerve terminal into a heavy chain and a light chain. The light chain is the key player here. It's a zinc-dependent protease, an enzyme that cuts proteins.
It cuts proteins inside the nerve.
Yes. This protease then prevents the release of acetylcholine from the presynaptic nerve terminal. It does this by interfering with the complex process of vesicle fusion, how the little sacs of AA merge with the nerve membrane to release their contents. Specifically, it acts like a microscopic pair of molecular scissors that snips vital proteins, like SNP25 or synaptobrevin 2, depending on the BoNT type, that are essential for acetylcholine release to occur.
So it stops ASAC release right at the source.
Precisely. This precise molecular interference with neurotransmitter release is what leads to localized muscle paralysis in the injected muscle.
Okay, so beyond its well-known cosmetic use for short-term treatment of wrinkles, what are its critical clinical applications for muscle relaxation?
Botulinum toxin has diverse and critical clinical applications in this area. It's become a highly useful treatment for various forms of generalized spastic disorders, particularly in conditions like cerebral palsy, especially when spasticity affects specific limbs. Its benefits, like reduced stiffness and improved range of motion, can persist for weeks to several months after a single treatment session, significantly improving the quality of life for these patients.
Useful for cerebral palsy spasticity. What else?
Botu-N-T has also virtually replaced older anticholinergic medications in the treatment of dystonia, which is a neurological movement disorder causing sustained involuntary muscle contractions and abnormal postures. More recently, it has received FDA approval for treating urinary incontinence due to overactive bladder by relaxing the bladder muscle, and also for the prevention of chronic migraine headaches.
Migraine too. Interesting. Are there different types?
Yes, there are different serotypes, with type A, like Botox, Dysport, Xeomin being the most studied and commonly used. But type B, Mitoblock, is also available and sometimes used if resistance to type A develops.
What about side effects and limitations?
Adverse effects can occur, sometimes related to the injection procedure itself, pain, bruising, or to the effect of the toxin, excessive weakness in the injected muscle or nearby muscles. Systemic effects are rare, but can include respiratory tract infections, generalized muscle weakness, urinary incontinence, falls, fever, and pain. While immunogenicity, the body developing antibodies against the toxin, making it less effective over time, was a bigger concern in the past, newer formulations and injection techniques have reduced this risk, but experts still generally recommend that injections not be administered more frequently than every 3 months to minimize it. A major practical limitation of BoNT treatment remains its high cost.
Okay. Is there a major safety warning associated with it?
Yes, there is. There's a very critical black box warning associated with all botulinum toxin products. This stems from post-marketing reports of systemic effects from the spread of the toxin away from the injection site. These effects can be serious and potentially fatal, including excessive generalized muscle weakness leading to difficulty swallowing or breathing. The risk appears greatest for children treated for spasticity, particularly those with underlying conditions, but it can occur in adults too, even with cosmetic use sometimes. The systemic spread is a very important safety nugget for the listener to be aware of.
Definitely a serious warning.
Yeah.
Okay, and then there's dantrolene, which you brought up earlier as unique, especially for malignant hypothermia. Let's revisit its mechanism. How does it work directly on the muscle?
Yes, dantrolene is indeed unique. It's a hydantorin derivative, structurally distinct from other relaxants, and its spasmolytic activity arises from a different mechanism. Unlike the centrally acting drugs or BONT, dantrolene reduces skeletal muscle strength by directly interfering with excitation contraction coupling within the muscle fibers themselves. It doesn't act on the nerve or the neuromuscular junction.
Interferes with excitation-contraction coupling. How?
To understand this, let's briefly recall normal muscle contraction. The electrical signal, action potential, that travels along the muscle fiber triggers the release of calcium ions from specialized internal storage sites called the sarcoplasmic reticulum, SR. This released activator calcium then binds to contractile proteins troponin within the muscle, initiating the sliding of filaments and thus contraction.
Okay, calcium release is key.
Absolutely. Calcium is released from the SR via a specific calcium channel known as the ryanodine receptor, RYR channel. In skeletal muscle, this is specifically the RYR subtype channel.
So how does dantrolene affect this?
Dantrolene works by interfering with this release of activator calcium from the SR. It does this by binding directly to the RIR1 channel and blocking its opening. By inhibiting calcium release, it prevents the sustained rise in intracellular calcium necessary for muscle contraction, thus reducing muscle strength and relieving spasm or rigidity.
It blocks the calcium channel in the muscle. Does it affect all muscles equally?
Interestingly, rapidly contracting motor units seem to be more sensitive to dantrolene's effects than slower responding units. And crucially, cardiac muscle and smooth muscle are minimally depressed by dantrolene.
Why not heart or smooth muscle?
Because their calcium release mechanisms, particularly for contraction, involve a different RYR channel subtype, the RIR2 channel in the heart, or rely more on calcium entry from outside the cell in smooth muscle. Dantrolene has much less effect on RIR2. This selectivity explains its specific action on skeletal muscle without significantly impairing heart function, for example.
That explains its specificity. How is it taken and what are the side effects?
Pharmacokinetically, only about 1/3 of an oral dose of dantrolene is absorbed, and its elimination half-life is approximately 8 hours. For treating chronic spasticity, the initial dose is typically 25 milligrams daily, gradually increasing up to maybe 100 milligrams 4 times a day, balanced against side effects. Major adverse effects include generalized muscle weakness, which can limit its usefulness, sedation, and occasionally potentially serious hepatotoxicity, liver damage, requiring liver function monitoring.
Okay. Now, its most critical application, the one that makes it truly life-saving, is in malignant hyperthermia. Tell us about that.
Yes, this is its most critical use. Malignant hyperthermia, MH, is a rare but potentially fatal heritable disorder of skeletal muscle. It's triggered in susceptible individuals by exposure to certain general anesthetics, specifically all the volatile anesthetic gases like halothane, sevoflurane, desflurane, and also by the depolarising neuromuscular blocking drug, succinylcholine.
What happens in MH?
Patients genetically susceptible to MH often have an underlying defect, frequently an alteration in that RIR1 calcium release channel, or sometimes an impairment in the SR's ability to resequester calcium after release. Upon exposure to a triggering agent, there is a sudden, prolonged, and uncontrolled release of calcium from the muscle's sarcoplasmic reticulum.
Massive calcium flood inside the muscle.
Exactly. This leads to massive, sustained muscle contraction and rigidity, a dramatic acceleration of muscle metabolism causing rapid lactic acid production, acidosis, and a profound, rapid increase in body temperature, the hyperthermia. It's a hypermetabolic crisis state that can quickly lead to muscle breakdown, rhabdomyolysis, kidney failure, cardiac arrest, and death if not treated promptly.
How does dantrolene help?
The prompt administration of intravenous dantrolene is the cornerstone of MH treatment and is absolutely essential. Starting with a dose of 1 milligram per kilogram intravenously and repeating rapidly as necessary, sometimes up to 10 milliduring kilograms or more, dantrolene works to control the acidosis and body temperature by directly attacking the underlying problem. It reduces that uncontrolled calcium release from the SR within the muscle cells by blocking the IR1 channels. It's truly a life-saving intervention in this specific scenario.
What about those everyday muscle strains or acute injuries from, say, lifting something heavy? That's a different kind of muscle pain than spasticity from a neurological condition. Are there drugs specifically for that?
Yes, absolutely. This brings us finally to the antispasmodics, drugs generally used to treat acute local muscle spasm resulting from injury.
Okay, the antispasmodics for acute spasm.
Right. This category includes a large number of less well-studied, centrally active drugs. Common examples include carisoprodol, soma, chlorzoxazone, Paraffin forte, cyclobenzaprine, flexerol, metaxalone, scalaxin, methocarbamol, robaxin, and orphanadrine, Norflex. These are typically promoted for the short-term relief of acute muscle spasm caused by local tissue trauma or muscle strains.
How are they thought to work?
While their exact mechanisms are not fully elucidated, it's generally thought that these drugs act primarily at the level of the brainstem, perhaps reducing tonic motor outflow rather than directly on the muscle fiber or significantly on the spinal cord's reflex arc in the way spasmolytics like baclofen do. Much of their effect might also be related to their sedative properties.
Okay, let's take cyclobenzaprine as an example.
Cyclobenzaprine may be regarded as the prototype of this group. Structurally, it's actually related to the tricyclic antidepressants.
Like amitriptyline.
Exactly. And as such, it produces significant antimuscarinic side effects like dry mouth, blurred vision, constipation, urinary retention. It's important to distinguish its use. Cyclobenzaprine is ineffective in treating muscle spasm due to cerebral palsy or spinal cord injury. Its indication is strictly for acute musculoskeletal spasms of peripheral origin.
Okay, main side effects.
Due to its structural similarity to TCAs and its strong antimuscarinic actions, cyclobenzaprine can cause significant sedation. It can also cause confusion and occasionally transient visual hallucinations, particularly in the elderly.
How is it typically used?
The typical dosage for acute injury-related muscle spasm is around 20-40 milligrams per day orally, usually given in divided doses for short-term use, maybe 2-3 weeks. It's also important to emphasize that this entire class of antispasmodic drugs carries risks of significant adverse events, including sedation, dizziness, and potential for abuse. As we mentioned earlier, carisoprodol, for instance, is a Schedule IV controlled substance due to its potential for dependence and withdrawal. These are generally not considered first-line agents for simple muscle strain. O4. Case study. A real-world application.
This has been an incredibly detailed journey through the science of muscle relaxants. To bring it all together and see how this knowledge applies, let's revisit that 35-year-old woman we introduced at the very beginning, the one scheduled for right knee surgery.
Right. Let's recall her key characteristics.
Okay, she's 80 kilograms, giving her a BMI of 32, so obesity is a factor. She has hypertension, insulin-dependent diabetes, she's taking an oral contraceptive, and crucially for anesthesia, she has a Malampati Class 3 airway, which indicates potential difficulty with intubation.
Okay, setting the scene. So the scenario unfolds. After induction of general anesthesia with propofol, rocuronium was administered intravenously to achieve skeletal muscle relaxation and facilitate endotracheal intubation.
Standard procedure so far.
Yes. However, upon attempting direct laryngoscopy, visualizing her vocal cords and airway proved impossible. Despite repositioning her head and trying different laryngoscope blades or techniques, intubation still couldn't be performed. Then things escalate. Bag mask ventilation, which is usually the backup, also became difficult.
A can't intubate, can't ventilate situation. That's an emergency.
Exactly, a true anesthetic emergency. This prompts the critical decision by the anesthesia team to abort the surgical procedure entirely and awaken the patient immediately. The central question in this high-stakes moment is, how do you quickly and safely reverse the profound neuromuscular blockade caused by the rocuronium?
So given everything we've learned, especially about reversal agents, what are the options for reversing the rocuronium in this critical scenario? And for our listeners to truly understand which one is the most appropriate and why.
Okay. In this specific high-stakes scenario, you essentially have two main pharmacological options for reversing the neuromuscular blockade induced by rocuronium. You could use sugammadex, or you could use the traditional combination of a cholinesterase inhibitor, typically neostigmine, combined with an anticholinergic agent like glycopyrrolate to counteract neostigmine's muscarinic side effects.
Two options. Which one is best here?
However, based on everything we've discussed, sugammadex would be the most appropriate agent to use in this scenario, by far.
Why sugammadex over neostigmine here?
Let's understand why this is a critical takeaway in this context. Neostigmine works, as we said, by inhibiting acetylcholinesterase, thereby increasing the level of acetylcholine at the neuromuscular junction to compete with the rocuronium. While effective for reversing partial or moderate blockade, if the patient is still fully relaxed from an intubating dose of rocuronium, which she likely is, given intubation was just attempted and failed, and now ventilation is difficult, the neostigmine will likely not be sufficient to achieve rapid and complete reversal.
It's not strong enough or fast enough for a deep block.
Exactly. It simply won't increase acetylcholine levels enough to overcome such a profound rocuronium block quickly enough in this emergency situation. In contrast, sugammadex has that unique and powerful mechanism. It actively binds rocuronium molecules and literally removes them from the neuromuscular junction and from the plasma.
The encapsulation mechanism.
Right. This binding creates that rapid concentration gradient, pulling rocuronium away from the receptors, leading to remarkably fast reversal. In a situation like this, where immediate reversal of an intubating dose of rocuronium is needed because of a failed airway, a sugammadex dose of 16 milligrams per kilogram should be administered intravenously.
The highest dose.
Yes, this high dose is specifically indicated for this exact situation, immediate reversal, and is designed to reverse the effect within that critical window of just 1.5 to 3.0 minutes. Speed is absolutely paramount when airway management is failing, and the patient needs to start breathing effectively on their own as quickly as possible.
That makes perfect sense. Speed and efficacy are paramount here. But you also mentioned potential problems with sugammadex, especially at higher doses and with specific patient characteristics. How would those considerations play into this patient's profile, the diabetes, the oral contraceptive?
An excellent point. This patient's profile brings up several crucial considerations for sugammadex use, truly demonstrating the complexity of clinical decision-making, even in an emergency. First, her insulin-dependent diabetes raises potential concerns about her underlying renal function.
Because sugammadex is cleared by the kidneys.
Precisely. Sugammadex is primarily cleared by the kidneys, and while it's generally not recommended for use in patients with severe renal impairment, creatinine clearance less than 30 ml/min, unless absolutely necessary, in this acute, potentially life-threatening, difficult airway scenario, the immediate benefit of achieving rapid reversal far outweighs the potential risk of prolonged sugammadex presence due to potentially reduced renal clearance. Furthermore, as mentioned, some studies have shown sugammadex can be dialyzed, offering a potential removal method later if prolonged exposure becomes a concern.
Benefit outweighs risk in the emergency. Got it. What about her birth control?
Second, and this is that vital patient counseling point we discussed earlier, she's taking an oral contraceptive agent. Sugammadex may interfere with the efficacy of progesterone-based contraceptives by binding to the progesterone component. Therefore, assuming she recovers safely, it would be absolutely necessary to counsel her post-procedure that she should use an alternative non-hormonal method of contraception, like condoms or a barrier method, for the following 7 days. This is an interaction that many might not immediately consider in the heat of the moment, but it's crucial for comprehensive patient care and avoiding unintended pregnancy.
Must remember that counseling point. Okay. Any other risks to consider?
Finally, yes, as we noted, sugammadex, particularly at this high 16 mg/kg dose needed for immediate reversal, comes with those other potential adverse effects. These include the small but real risk of anaphylaxis, the possibility of marked bradycardia, which can progress rapidly to cardiac arrest, requiring vigilance and atropine availability, transient hypotension, potential nausea, vomiting, headache, and that temporary coagulopathy. In this emergency, while these risks are present and need to be anticipated, the immediate need to reverse the paralysis, secure the patient's spontaneous ventilation, and awaken her safely takes absolute precedence.
So manage the risks, but reversal is the priority.
Exactly. This case beautifully highlights the incredible precision required, the calculated risks involved, and the innovative solutions like sugammadex that are available in modern pharmacology to manage complex and critical situations.
What an incredible example of modern medicine in action. That complex, real-world scenario truly brings home the incredible precision, the inherent risks, and the groundbreaking solutions available to clinicians. It's a real testament to how deep pharmacological understanding can make the difference between a crisis and a safe outcome. Outro. As we wrap up this deep dive, it's crystal clear that skeletal muscle relaxants are far more than just simple muscle relaxers. We've journeyed from the ancient Amazon, understanding how a primitive arrow poison, curare, gave us the blueprint for modern neuromuscular blockers.
Like d-tubocurarine.
Right. Drugs that provide life-saving paralysis during surgery. We looked at the fascinating competitive block of drugs like rocuronium and the swift, if sometimes complex, action of succinylcholine.
And we've also explored that distinct world of spasmolytics and antispasmodics. the drugs designed to bring relief from chronic spasticity or acute muscle pain. We dissected the intricate mechanisms of drugs like baclofen acting at the GAB receptor or tizanidine with its unique alpha-2 agonism.
Yeah, and we dove deep into the precise molecular dance happening at the neuromuscular junction, appreciating details like the spontaneous Hoffman elimination that makes cisatracurium safer.
The clinical significance of the dipukane number for predicting succinylcholine response.
And that truly revolutionary molecular cage mechanism of sugammadex for reversing specific blockers.
What's truly striking, I think, is the delicate balance clinicians must navigate between inducing profound paralysis when needed and providing targeted muscle relaxation for chronic conditions. And understanding the intricate ways these compounds interact with our physiology, sometimes with surprising and critical implications, like the drug interactions or patient-specific factors, really demands that expert, nuanced understanding we aimed for.
Absolutely.
Absolutely. Understanding skeletal muscle relaxants isn't just about memorizing drug names or mechanisms. It's really about appreciating the incredible complexity of our own neuromuscular system and how precise pharmacological intervention can literally control the difference between movement and stillness, sometimes life and death. As we've seen today, every detail from a single ion channel's behavior to a patient's unique genetics to the other medications they might be taking plays a critical role. Hopefully this deep dive leaves you not just informed, but genuinely curious about, well, what's next? What's the next frontier in controlling human movement, in easing suffering from spasm and spasticity, and maybe also thinking about the ethical considerations that inevitably come with having such powerful control over muscle function. What aspect of this control most fascinates you now, and how might these advancements continue to change the future of medicine and patient care?